Hello everyone. So this particular part talks more about assessment and it's a review of anatomy and physiology. So I'm really hoping that we aren't going to spend a whole lot of time on this, but we'll do a real quick review. When we look at the visual system, it consists of the external tissues and structures that surround the eye, the external and internal structures of the eye, and the refractive media and the visual pathways to the brain. And so if anything is wrong with one or another part of the visual system, it causes problems for visual function. When we look at it, the external structures include the eyebrows, the eyelids, the eyelashes, the lacrimal system, the conjunctiva, and the sclera. The cornea and the extraocular muscles also play an important role in the vision. The internal structures include the iris, the lens, the ciliary body, the choroid, and the retina. And what we know is that light is reflected through the structures of the eye. It's refracted, which is another way of saying that it's bent as it goes through the eye, and then it falls on the retina. And how that is signaled to the brain is perceived as the image that we see. So some of the things that I wanted to do, and you'll actually see this illustration show up twice on this. When we look at the structures and functions of vision, we can see the eyeball itself, which is known as the globe, and it consists of three layers. The tough outer layer comprises the sclera and the transparent cornea. The middle layer consists of the uveal tract, which is the iris, the choroid, and the ciliary body. And then the innermost layer is the retina. The anterior cavity is also divided into the anterior and posterior chambers. The anterior chamber lies between the iris and the posterior surface of the cornea, and the posterior chamber lies between the anterior surface of the lens and the posterior surface of the iris. The aqueous humor is this clear, watery fluid that fills the anterior and posterior chamber of the anterior cavity of the eye. It's produced by capillary blood in the ciliary body and drained away by the scleral veins through the canal of Schlemm and back to the body. The posterior cavity lies in the large space behind the lens and in front of the retina. So when we look at the structures and the functions of vision, we have to look at the mediums of the eye that make that happen. So for the light to reach the retina, it has to pass through all these different structures. And they all have to remain clear for the light to reach the retina and to stimulate the photoreceptor cells. The transparent cornea is responsible for most of the light refraction that's necessary for us to see well. The aqueous humor bathes and nourishes the lens and the cornea, and the excess production or decreased outflow of the aqueous humor can elevate the intraocular pressure. So the intraocular pressure is normally between 10 and 21 millimeters of mercury. And if it's higher than that, that's what we start calling glaucoma. The lens itself is a biconvex structure. It's located behind the iris, and it's supported in its place by some small fibers that collectively are called the zonule, and that connects the lens to the ciliary body. The primary function of the lens is to bend that light ray so that it falls onto the retina. Its shape influences accommodation, and you know from doing your assessment checkoffs that accommodation is a process that allows a person to focus on near objects, like when you're reading, and at the same time still be able to accommodate or look out into the distance. And then finally, the transparent gel-like vitreous humor is in the posterior chamber, and it also needs to be clear for effective vision. When we look at the structures of vision and looking at refraction, refraction is the ability of the eye to bend the light rays so that they fall on the retina. And when the light doesn't focus properly, it's called a refractive error. The types of refractive errors are nearsightedness and hyperopia or farsightedness. Astigmatism is an uneven curvature of the cornea which results in visual distortion. And presbyopia is the loss of accommodation that results in an inability to focus on near objects. And most people start getting presbyopia around the age of 40, and it progressively gets worse. And what happens with it is that if you're focusing on something near, then when it comes time to look and focus on something farther away, the items that are farther away will appear blurry because the eye isn't accommodating to change from looking at things up close to then looking at things far away, or vice versa. The visual pathway, so look at this little illustration here. Once the image travels through the refractive medium, it focuses on the retina. From the retina, the impulses travel through the optic nerve to the optic chiasm, where the nasal fibers of each eye crosses over to the other side. And fibers from the left field of both eyes form the left optic tract and travel to the left occipital cortex. And the fibers from the right go through the right optic tract and travel to the right occipital cortex. So as you can see, if you have problems with the right side, right eye, it's going to be processed on the left side. So this arrangement of the nerve fibers in the visual pathways allows determination of the anatomic locations of abnormalities. So when we look at the external structures and their functions, primarily they are a physical barrier to protect the eye. The eyebrows and the eyelids and the eyelashes all serve an important role to keep dust and dirt out of the eyes. And they provide that physical barrier for those foreign particles. The eye is further protected by surrounding the bony orbit and the fat pads that are located below and behind the globe and the eyeball itself. The upper and lower eyelids join at the medial and lateral canthi. So canthi is plural for canthus. So when we think about the inner canthus and the outer canthus, it's also known as medial. Medial meaning the inner canthus, and lateral would be the outer canthus of the eye. The conjunctiva is, oh wait a minute, I want to go back about that. The eyelids open by action of the cranial nerve, specifically the cranial nerve, the third cranial nerve, which is the oculomotor nerve, and they close through an action of the muscles innervated by the seventh cranial nerve, or the facial nerve. The conjunctiva is a transparent mucous membrane that covers the inner surfaces of the eyelids and extends over the sclera, and it forms a pocket under each eyelid. So you all know when we give meds that we make that little pocket come out so that we can give the medications in there. The glands in the conjunctiva secrete mucus, and it also secretes tears. And blinking of the upper eyelids distribute the tears over the anterior surface of the eyebrows or the eyeball, and it nourishes the surface cells. And tears produced by the lacrimal gland pass over the surface of the eye and enter the lacrimal canal. And from there, the tears are carried through to the lacrimal duct and then into the nasal cavity. And it's what, when we have allergies, we have excessive production from the lacrimal glands. And that's what causes us to have that runny nose and everything. It's really not so much our nasal passages that are being irritated, although they are, as it is that in many cases that our eyes and the conjunctiva is being irritated, and it's making the increased secretions which are causing us, as it goes into the nasal cavity, to make us have a runny nose. The sclera comprises collagen fibers that are meshed together to form an opaque structure, and is commonly referred to as the white of our eyes, and it forms a tough shell that helps protect the intraocular structures. When we look at the iris is what produces the color of our eyes. The small opening in the center is the pupil, and it's through the pupil that light enters the eye. The pupil dilates and constricts with two muscles controlled by cranial nerve 5 and 3. 5 is the trigeminal nerve, and 3 is the oculomotor nerve. The lens is located behind the iris, and we talked before about how it's biconvex. It's also avascular, so there's no vessels in the lens, and it should be transparent. The muscles of the ciliary body around the lens contract to change the shape of the lens to help us focus in. Another component of the ciliary body, the ciliary processes, lie behind the peripheral part of the iris and secrete into the aqueous humor. The choroid lies inside and parallel to the sclera. It's highly vascular, and it serves to nourish the ciliary body, the iris, and the outer portion of the retina. The retina itself is the innermost layer of the eye. It's composed mostly of neurons and extends from the ciliary body to form the optic nerve. It contains specialized nerve cells that are responsible for color vision and also translating visual images into stimuli that the brain can actually interpret. One of the things that I want to point out, because many people have this idea that the retina is only on the back side of the eye, but in this illustration, if you look in the area where you see sort of that dark area with lines on it up by the lens, the retina goes all the way from that area to the back. So when your eye doctor is asking you to look up, look around, and he's got the bright light shining in your eye, what he's looking at, or she is looking at, is they're looking at the retina all the way from the side of your lens to the other side of the lens and across the back. And so it really covers a much larger area than most people think about. But if you think about it, that makes sense, because that's how you get your peripheral vision. If you didn't have that retina area all the way up to the front of your eye, you wouldn't have the peripheral vision that you have. The retina is composed of two types of photoreceptor cells, rods and cones. The rods provide vision in dim or darkened environments, and the cones are receptive to colors in bright environments. The central region of the retina is called the macula. It's usually about 6 millimeters in diameter, and it's responsible for our central visual field. So if you have any damage that happens to that part of the eye, you lose that ability for fine vision, so reading and stuff like that. You may have your peripheral vision, but you won't have the fine vision that you need for reading, for instance. The fovea centralis is located in the center of the macula, and it's composed of densely packed cones. This area of the retina provides the sharpest visual acuity, which is necessary for activities importance like reading and driving, also any kind of close-up type work that we may do. As we age, every structure of the visual system is subject to change. Often it's due to decreased perfusion and oxygenation of the part of the eye that's affected. Some of these changes are benign, but others can lead to serious loss of vision. So, for instance, when you have presbyopia, yeah, it's annoying, but it's not going to lead to serious loss of vision. But if you have cataracts or you have glaucoma, which is can also be part of the aging process, or macular degeneration, which is also affected by changes in perfusion to the eye, those things can cause serious loss of vision. Poor vision and blindness can have a significant psychosocial implication. My mom had macular degeneration, and we're not going to really go too much into macular degeneration in this talk, but with macular degeneration, the macula, where we see the most, starts to have less circulation in it, and with that, they lose vision. And because of that, my mom talks to me a lot about how she can see, but she can't see. She can't read. She can't drive because her vision isn't good enough to do either one of those things. She talks to me about how when she retired, how she thought she was going to be able to do so many things that would benefit other people, but instead she can't see to do those, and so it limits her ability to do the things that she had hoped to do. Those age-related changes in the visual systems and the differences in assessment findings are on your table 20.1. This particular one looks like it could have some glaucoma, although I really think it looks mostly like glaucoma. It could actually have a cataract as well, because you can see that the lens doesn't look like you can see through it well, but that also happens with glaucoma. And we'll talk about that in chapter 21, which is our next video that's coming up. So when we assess visual field, we have to do all of look at the history. We have to find out what's going on. So we want to look at past health history. It can be, when we do these assessments, it can be as simple as just doing visual acuity, or it may be more complex, especially if the person is having more complex visual problems. Some of the information that we want to look in their past history about should include both their ocular and their non-ocular information. Patient information obtained should include past eye health and family history with eye problems. We should also look at histories of specific diseases and medications that are known to cause visual problems, including things like systemic diseases, like cardiac and pulmonary disease, because the beta adrenergic blockers that are often used to treat glaucoma can cause slowing of the heart rate. So if you've got somebody with decreased blood pressure, it could exacerbate their asthma or give them more problems with their COPD. We want to look at past history visual tests, the date of their last exam, and changes in their prescriptions, and if there's been any head or eye trauma during that time period between those exams. The patients usually don't think that over-the-counter drugs, eye drops, or herbal therapies are real drugs, and they might not mention them unless we specifically ask for them. So we want to make sure that we ask, because many of these herbs have ocular effects. Many of the cold preparations contain a form of ephedrine, pseudoephedrine in them that can dilate the pupils. The antihistamines and the decongestants can cause ocular dryness. So, somebody who's complaining of dry eyes, well, maybe they're taking a lot of allergy meds. Specifically ask whether any prescription drugs like corticosteroids, thyroid medications, or agents like oral hypoglycemics and insulin have been given, because or any meds to lower their blood pressure, if they're using any of those. And we also want to look at long-term use of corticosteroids because they can contribute to the development of glaucoma or cataracts. So if you think about our endocrine patients, somebody who has Cushing's disease may have problems with glaucoma or cataracts. We also want to find out about any surgical procedures that have been related to their eye or their brains, and document any laser procedures that have been done on the eye, because those laser procedures often will cause problems with their vision. We also want to look at functional health patterns. The ocular patterns don't always affect visual acuity, but the focus on the functional health patterns depends on the presence or the absence of visual loss, and whether the loss is permanent or if it's just a temporary loss. Some of the patient's characteristics like gender and ethnicity and age are important in assessing the ophthalmic conditions. For instance, men are more likely than women to have color blindness, and the leading cause of blindness among African Americans is glaucoma. And if you think about it, that's often related to the incidence of high blood pressure in African Americans. Older individuals are also at higher risk for glaucoma, and you need to assess how the patient perceives their current health problems. Are they able to perform their work? And can they do things at home that they've always been able to do, or they're having more problems doing it because of their visual difficulties? And are they able to accomplish self-care? Other functional activities that we want to look at include things like advising them to wear protective eyewear during hazardous activities, avoiding noxious fumes or other eye irritants, using sunglasses in bright light, asking whether they're having problems driving at night. You'll often find that as people get older, that they will talk about how they don't like to drive at night, that they just don't see as well at night as they used to, and they would rather not drive at night. If they're using their contact lenses appropriately and if they're cleaning them properly. You also want to obtain information about their allergies. And the other things that we have to think about is there a hereditary reason why these people are having visual problems? Because we often see hereditary diseases like sickle cell affecting vision, and a family history of atherosclerosis, diabetes, hypertension, arthritis, or cancer are often associated with visual problems. We also know that certain eye diseases like cataracts and tumors and refractive errors, especially myopia and hyperopia, or retinal degenerative conditions like macular degeneration and retinal detachment, have a hereditary basis. And also certain types of glaucoma have a really strong genetic link. So in my family, my children are all nearsighted. I'm farsighted, and my granddaughter is farsighted. Her mom and her dad are both nearsighted. And so some comment was made one day about, well, how come she's farsighted? Nobody else in the family is. And it's like, no, I'm farsighted. And she's like, I'm your twin, Grandma. I'm just like you. And it's like, well, our eyes have the same problem. And, that's a genetic thing. It skipped her dad, but it landed with me. I landed with her, and so she inherited my farsightedness. Other things that we need to look at is nutritional and metabolic patterns, especially things like whether or not the person has a high enough level of antioxidants, because these have been found to reduce the age-related macular degeneration. And I'll talk a little more about the nutritional kinds of things when we're talking about cataracts. We want to evaluate the potential for constipation because straining will cause a Valsalva maneuver to happen, and that can raise the intraocular pressure, and that especially is contraindicated after eye surgery. We want to assess impact of reduced vision and the symptoms of the ocular problems or post-op activity restrictions on the usual level of activities or exercise patterns as well. And then we want to inquire whether the patient uses safety precautions like protective goggles when participating in sports or leisure activities, which I think is a really interesting way of saying things like, are you protecting your eyes when you're doing construction work around your house, or you're doing woodworking, or other things like that, where we have to be concerned about things flying up and injuring the eye. We want to assess disruptions in sleep because ocular irritation can be a problem for contact lens wearers and potentially caused by painful eye problems. And you don't want to overlook cognitive and perceptual problems such as hearing and memory loss because those can complicate post-op and other teaching instructions if they require operative care for their visual problems. You also want to assess eye pain, any kind of treatments that we're doing for the eyes, and how they're responding to those treatments. In addition, I know this seems to go forever and ever, we want to look at self-perception and the self-concept. You want to evaluate potential effects of vision loss, even if it's temporary, on the person's self-image, their self-concept, and their loss of independence. Like the inability to drive can be really devastating. I remember when that happened with my parents, it was so difficult for them when they realized that they really did not have the vision necessary to drive. And they kept their car for a really long time. It was a really long time, like the gas went bad in the gas tank. And because they really just couldn't, they had difficulty giving up. Giving up the car meant that they really were giving up their ability to drive. We want to assess if the ocular problems impact the ability to perform any necessary or desired roles and responsibility at home, at work, or in social environments. We also want to look at how severe vision loss can affect self-image to the point that it diminishes sexual interest, intimacy, and expressiveness. We want to assess a patient's inability or their ability to cope with temporary or permanent visual problems. We want to look at their coping mechanisms and the availability of social and personal supports. When my mom lost her vision, one of the first things that they did was start to contact organizations that help people with blindness. And she was willing to take some of the information or some of the products and teaching that they offered, but she wasn't willing to take other parts. And so we have to look and see how people are able to change their self-concept when they lose a vital sensory system. You want to be sensitive to the values and the spiritual beliefs that guide people's decisions as far as accepting, requesting, or denying care. Sometimes it's not so much their spiritual beliefs. Sometimes it's more of their feelings of, I'm not going to let anyone know that I can't see. And so it took a long time for my mom to start having a white cane with her, but she finally accepted that as well. So let's look at a case study. AO is a 74-year-old male, and he comes into the clinic for an eye and ear exam. What are some reasons you may want to involve his wife, and how would you go about it? Well, HIPAA, you do have to get his consent for his wife to be involved in the conversation. He may not even be aware of some of his deficits because he's in denial, or he just is unaware of what happens with it. But his wife may notice those things. And she may have history that is important for you to know that he either doesn't want to share or he's forgotten to add. If he's having any cognitive issues, he may not be capable of providing an accurate clinical picture. And totally off topic, my dad ended up with a pacemaker. And when I talked with the doctor said to me, and I was telling her some of the things that I knew about the situation. She said, your parents are very poor historians. My parents are very poor historians because my mom has a very strong privacy need, and she doesn't always share all the information that she should share, even with her physician. And this can happen when people start having hearing or vision losses. They don't want to think about that. And so they don't always tell people how bad their vision really is or what would be helpful. And I know even right now, my mom's she had macular degeneration, lost her vision to macular degeneration. Now she has cataracts that they could do surgery on, but they won't do surgery because of her macular degeneration and the amount of vision that she lost with that. The problem is that She had usable vision while before the cataracts came up, and now that the cataracts are getting worse, she doesn't have that peripheral vision that she had before. And so instead of having just the inability to read and really focus in on things, now she can't see at all. And so she's really lost all of her vision because of the cataracts. So, but she is not expressing that to her physician. And I don't know if they would do anything different if she actually told them about that, but she chooses not to tell them that. So so sometimes when there is a spouse or someone else from the family present, they're able to express things that the patient may not express themselves. When we look at objective data, the physical exam is important. And in this case, we're looking at the eyes. We're not really thinking about the whole body when we're talking about the physical exam here. So it might be as brief as measuring visual acuity or in-depth and requiring special training. It's always based on what is appropriate and necessary for that specific patient. Some of the physiologic functional assessments include determining the patient's visual acuity, the ability to judge closeness and distance, and extraocular muscle functions. Also evaluating their visual fields and their pupil functions, and measuring the intraocular pressure. So for those of you that are going in and getting your eyes examined regularly, you know that they check the pressures of your eye. We want to also do an assessment of the ocular structures, including examining the ocular external eye and the internal structures. And we also want to do assessment techniques that require special training, but all are within your scope of practice, like looking at the retina, the blood vessels, the optic disc, but those have to be assessed with an ophthalmoscope. When we do that initial observation, we're going to look for any unusual color combinations or head positions, covering the eyes with their hands, or an awkward hand extension with a handshake. Those can all indicate visual problems. We want to look for symmetry of the eyes and note any bulgings or sunken appearances of the globes. We're always going to record visual acuity for medical and legal reasons before the patient receives any care, and then position the person on a mark exactly 20 feet from the Snellen eye chart. If the person wears glasses or contacts, you leave them on. You cover one eye at a time during the test. Usually we assess the right eye first, and then ask the person to read through the chart to the smallest line of letters possible. And then record the result using the numeric fraction at the end of the last successful line read. You indicate whether any letters were missed and if corrective lenses were worn. So in other words, you might say the right eye was 20/32 with contacts. Normal visual acuity is 20/20, and the first number indicates the distance the person is standing or sitting from the chart, and the second number gives the distance at which a normal eye can read that particular line. And next you ask the patient to cover the right eye, and the process is repeated with the left eye. So Mr. AO looks tired and his eyes are sunken, so what should you ask? Well, we're going to do a focused assessment of sleeping patterns and possible causes of interference. And we also want to inquire about his nutritional status and how much he drinks. He may be dehydrated. Remember, sunken eyes can be a sign of dehydration. So we want to find out their fluid balance as well. Other things that we may look at is legal blindness. and it's defined as the best corrected vision in the better eye of 2200 or less. So in other words, if only one eye has poor vision, you are not considered to be legally blind as a whole, but you are legally blind in that eye. If both eyes are severe, you are legally blind based on the better eye. If it's 2200, or when we say less, meaning that we're not seeing the big E. If the patient reports near vision difficulty or they're 48 years of age or older, you would also want to use a handheld vision screener with varying print sizes. That's called a Jaeger eye chart. And the card is held at 14 inches in good light from the eye to assess near vision. And each eye is examined separately with their glasses on. The normal result is 14/14 in each eye, read without hesitancy and no movement of the card by the patient. Any hand motion or light perception, we may need to do that for distance vision assessment if a specific chart for distance isn't available. You must assess near visual acuity without access to a Jaeger chart. An accurate assessment is still possible. We can do it by having other things like reading newsprint or the label on a container, and then you record the acuity as reads newspaper headline at blank inches away, or reads newspaper article at 14 inches, or however many inches it is. Some of the other objective, we're going to observe the corneal light reflex to evaluate for weakness or imbalance of the extraocular muscles. So in a darkened room, you ask the patient to look straight ahead while you're using the pen light shown directly on the cornea. The light reflex should be located in the center of both corneas as the patient faces the light source. Remember, both eyes respond even though the light is only shining in the one eye. You should be seeing a response on both sides. We also are going to assess eye movement by taking a finger or an object 10 to 12 inches from the patient's nose, and we ask them to follow with their eyes only the movement of the object in the 6 cardinal positions of gaze. So right up, left up. We do one eye at a time, so like right up, straight to the right, and then right down, and then left, down, left up. Usually we make a circle out of it. It can indicate weakness or paralysis of the extraocular muscles and the cranial nerves. Also, we look at pupil function, and it's determined by inspecting the pupils and the reaction to light. So perla means that the pupils are equal, PE, pupils equal, round, reactive to light, and accommodation. So we want to see that the pupils look like that. And the pupil, there's a small percentage of the population that has pupils that are unequal in size, and that's called anisocoria. The pupils should react to light directly, in other words, constricting when the light shines into the eyes. And the pupil should react to light consensually, meaning that when the light shines into the opposite eye, it constricts in both eyes. Finally, we're going to do intraocular pressure, and it can be measured by a tonal pen, like what they're showing in this picture. And like we said before, normal intraocular pressure ranges between 10 and 21. Other things that we look at are the eyebrows, the eyelashes, and the eyelids. We look for symmetry or deformity, um, and the eyebrows and the eyelashes should be present and symmetric. There are some people that pluck out all of their eyebrows, but in general, you should still be able to see where they ought to be. And they shouldn't have any deformities, redness, or swelling. The eyelashes should extend outward from the lid margins, and they should not touch in normal closing. The lacrimal puncta should be opened and positioned properly against the globe. The conjunctiva and the sclera should be evaluated for color, smoothness, and presence of lesions or foreign bodies. The conjunctiva covering the sclera is normally clear with fine blood vessels visible, and it's more common for the blood vessels to be in the peripheral areas. A pale blue cast can be caused by scleral thinning, and that can be normal in older adults. Remember too that when we talked in pediatrics about kids that had osteogenesis imperfecta, one of the things that they had was a very thin sclera, and that caused them to have a blue tone to the whites of their eyes. A slight yellow cast can be found in some dark-skinned persons, such as African Americans and Native Americans as well. And the cornea should be clear, transparent, and shiny. The iris should appear flat and not bulged towards the cornea. The area between the cornea and the iris should be clear with no blood or purulent material visible in the anterior chamber. Both irides, which is the plural for iris, should be of similar color and shape. A color difference between the irises occur normally in a small portion of the population. And I think about people that have flecks of other colors in their iris. Sometimes one iris will have more flecks in it than the other one does, so it will look like the color is a little bit off on one compared to the other. In order to look at the retina and the optic nerve, you need to use an ophthalmoscope to magnify the retina and to be able to bring them into a crisp focus. And this is what it would look like if you were looking at the eye. The optic nerve of the disc is examined for size, color, and abnormalities. It's usually a creamy yellow color with distinct margins. The central depression in the disc is called the physiologic cup, and it may be seen. This is the area where the optic nerves exit out of the eye. The cup should be less than 1/2 of the diameter of the disc. Normally, no hemorrhages or exudates are present in the fundus when you look at it, and if you carefully inspect it, it could reveal the presence of retinal holes, tears, detachments, or lesions. Small hemorrhages can be associated with diabetes or hypertension, and they can appear in various shapes like dots or flames. The macula is also examined for shape and appearance. It tends to be very reflective, and because it doesn't have a lot of blood vessels in that area. Also important information about the vascular system and the central nervous system can be obtained by looking at the retina with the ophthalmoscope. Usually as nurses we don't do that a lot, but if y'all become ophthalmic nurse practitioners, you would probably look at it a little more often. Another thing that we want to do is check for color vision changes. This is done with an Ishihara color test, and these are all examples of the Ishihara color test. And if you aren't seeing numbers and shapes in these pictures, you may have a lack of color vision, which tends to be more common in men. So guys, can you see it? The one picture in the upper right-hand side, usually when we look at that, they'll actually ask the person to follow the design, the line of orange dots to show that they can see it. Otherwise, they'll just say, what do you see? And, if you see the number 15 or you see the number 57, you just say that that's what you're seeing, and that tells them that you have color discrimination. Stereoscopic vision allows the patient to see objects in 3 dimensions. Monocular vision from inoculation or patching results in a loss of ability to judge distances, including the height of a step or following too closely behind another vehicle when driving. It can also happen when people have macular degeneration in one eye, because we need both eyes to be able to determine distance. And without the vision of both, that input from both eyes, we tend not to see the distance as well. Some of the diagnostic studies may be a refractometry. They may do ultrasound of the eye. They may do a fluorescein angiography. So just like an angiography of the heart, they put in dye, and then the dye goes up into the eye, and they can see the blood vessels better with those. And the Amsler grid test, which is on my next slide, can show whether there's changes in the retinal surface. So, for instance, the grid to the left is how we should normally see it. But if somebody has macular degeneration, they may see it like the one to the right. So you notice that AO has 2 different colored socks on. Is this important? Why or why not? And what do you say to him about his socks? So it could indicate color blindness, which may complicate driving if the patient's vision or function declines with illness or age. It may influence self-concept if they're unable to compensate in other ways, so that, for instance, they wear the same color socks. It may not be a factor related to work performance because, he's old and probably not working, but it could influence what he does for his leisure or his recreational activities. It could be important if related to cognitive decline, and definitely needs further assessment. Be respectful, but ask his wife and or him about it, and possibly using a lightheartedness or humor, like, hey, I noticed you got 2 different socks on. Did you know you had 2 different ones? And they could say, oh, I'm so embarrassed. We did laundry the other day and somehow only got 1 of each sock in, and those are, he doesn't have a lot of good socks, and he didn't want to wear his white socks in, so he's got these on, and you'll see a navy and a black or something like that. So make it lighthearted so they're not too embarrassed about it. When we look at the auditory system, it consists of peripheral and central systems. The peripheral system includes the external, the middle, and the inner ear, and it's involved with sound reception and perception. The central system, the brain and its pathway, integrates and assigns meaning to what's heard. The external ear consists of the auricle, or the pinna, and the external auditory canal and tympanic membrane. The auricle is composed of cartilage and connective tissue, and the external auditory canal is slightly S-shaped, about 1 inch in length, and the proximal third of the canal is lined with fine hairs or cilia, sebaceous oil glands, and cerumen or wax glands. The distal 2/3 of the canal is lined with a thin epithelium over the bone, and it's very sensitive. The function of the external ear and the canal is to collect and transmit the sound waves to the tympanic membrane. The eardrum is a shiny, translucent, pearl gray membrane that serves as a partition and an instrument of sound transmission between the external canal and the middle ear. In the middle ear, it's an air space that's located in the temporal bone. The eustachian tube connects the middle ear to the nasal pharynx, and it functions to equalize the atmospheric air pressure between the middle ear and the throat. You know, we talk about our ears popping when we change altitudes, and it allows the tympanic membrane to move freely. It's normally closed and opened with movement of the jaw, usually with yawning and swallowing. And blockage can occur with allergies, nasopharyngeal infections, or enlarged adenoids. When the eustachian tube remains open, it's referred to as patulous. When this occurs, the person can hear their own voice. They call it autophony. And vibrations of the tympanic membrane cause the ossicles, which are the bones in the ear, to move and transmit sound waves to the oval window. The mastoid is the posterior part of the temporal bone, and the facial nerve, which is the cranial nerve 7, traverses above the oval window of the middle ear. The thin bony covering of the facial nerve can become damaged by chronic ear infections, skull fracture, or trauma during ear surgery, and it results in problems related to voluntary facial movements, eyelid closure, and taste discrimination. So if you think about the middle ear, we talk about the malleus or the hammer, the incus or the or the stapes, which is the stirrup, the anvil. That's what I was thinking about with the incus. And so these bones somewhat resemble those things outside of the body. In the inner ear is the functional organ for hearing and balance. It comprises a bony labyrinth, or a labyrinth is this circular maze surrounding a membrane. The receptor organs for hearing is the cochlea, and it's a coiled structure, and it contains the organ of corti, and those in the organ of corti, there's tiny hair cells that respond to stimulation of portions of the membrane according to pitch. The stimulus is converted to an electrochemical impulse, and then that's transmitted to the acoustic portion of the vestibular cochlear nerve, which is the cranial nerve 8, to the temporal lobe of the brain to process and interpret the sound. There's 3 semicircular canals, and the vestibulae that make up the organs of balance. These structures comprise the membranous labyrinth, which is housed in the bony labyrinth. Membranous labyrinth is filled with endolymphatic fluid, and the bony labyrinth is filled with perilymphatic fluid. And the nervous stimulus are conducted by the vestibular portion of the cranial nerve 8. There's debris such as loose crystals of calcium or excessive pressure within the lymphatic fluids can produce disorders like vertigo. One of the things that they didn't mention is that there's actually some little stones, they call them otoliths, that are there, and as they move on the hairs of the cochlea, it tells your body whether you're upside down or right side up, and that also is part of your balance. Obviously, we look at the structures as far as transmission of sound. The external and middle ear conducts and amplifies sound waves from the environment. That's called air conduction. And so problems in these areas cause conductive hearing loss, which changes the sound perception and sensitivity. The bones of the skull can also transmit sound directly to the inner ear. We call that bone conduction, and we test it with a tuning fork. Inner ear functions in hearing and balance. These problems are located in this area or along the nerve pathway from the brain that can cause sensorineural hearing loss. And with that, we see changes in tone perception and sensitivity. The central auditory system problems cause central hearing loss with difficulty understanding the meanings of words. We often see that with people after they've had a stroke. And the vestibular apparatus in the inner ear is critical to maintaining position, sense, and equilibrium. So just like we had presbyopia, we have presbycuspis. And it's the hearing loss that's the result of aging. About 20% of American adults report some degree of hearing loss as they age. Presbycuspis can result from aging or a variety of other sources like noise exposure, some systemic diseases, poor nutrition, ototoxic drugs, buildup of earwax, and pollution. Usually it's worse for high-pitched sounds rather than the lower-pitched sounds. So people with a higher pitched voice, they may not hear them as well as somebody who has a deeper pitched voice. Tinnitus or ringing in the ears can accompany the hearing loss that results from the aging process, and age-related changes of the auditory system can result in impaired hearing, which can have serious implications for the quality of life, including psychosocial and physical dysfunction. So when we're assessing, we want to check for auditory and vestibular problems. Vertigo is usually stimulated by movement of the head, and it feels like persons or the objects around the person are moving or spinning. So we're going to ask them about things like that. Do they have dizziness? Or do they have nystagmus, which is an abnormal eye movement that's often seen as twitching of the eyeball, and they'll often describe it as blurring of vision with their head or eye movement. Some of the other things that we will look at is past health history as a childhood, like did they have frequent ear infections? Did they have any kind of surgical procedures like tubes in their ears, or a tonsillectomy or an adenoidectomy? Was there any perforations of the eardrum? In other words, like did they get such a bad ear infection that their eardrum broke? Have they been on any ototoxic medications? Have they ever had draining of their ears? Did they have measles, mumps, or scarlet fever as a child? We want to know about past auditory tests, if there's other family members that have hearing loss, because often hearing loss is a congenital disorder. And some of the drugs, back to the drugs, that can cause hearing loss include aspirin, certain antibiotics, especially gentamicin and vancomycin, chemotherapy agents, diuretics, especially furosemide, is known for hearing loss, and NSAIDs. They can be reversible if the treatment's stopped, but sometimes they don't catch it soon enough. We want to know if they've had previous wax impactions or surgeries on the ear itself, and then if they've used hearing aids before, and what was their experience with it. Was it something good? Did it work for them, or was it something that they were unsatisfied with? We also want to look at how it affects their daily life. We want to know whether it's a sudden hearing loss that occurred or whether it was a gradual hearing loss that others were noticing. We want to note safe use of hearing aids, safety practices, and swimming habits. We want to assess alcohol, sodium, and use of dietary supplements. Those could exacerbate Meniere's disease, which is when people are chronically dizzy. We want to note problems with chewing and swallowing, dental problems, dentures, and also clenching or grinding of teeth, because that's related to TMJ, which can also affect hearing. Post-op straining with bowel or bladder elimination is important for healing with many procedures, and so we don't want them to be constipated. And looking for other things that may affect their daily living. In addition, we want to look at their ability to pay attention, follow directions. We're going to ask others if they have noticed any changes in the patient's hearing. We want to ask these questions very sensitively because some patients find it very alarming to think that they may not be hearing. And hearing loss and vertigo are really distressing for patients, and they could become embarrassed or be accused of intoxication, especially with vertigo. It can cause strain in family and social relationships. It can affect their ability to do their activities of daily living. Obviously, their sex life could be affected as well. And so you want to assess also for denial of any hearing problems or usual coping styles, their stress management, and evaluate any home remedies that they may be using. We're going to observe for behavioral adjustments, indicating hearing distance difficulties. They may deny it, and they may not even realize that they've lost their hearing until they have a moderate loss. So you notice that when you're talking to Mr. AO, remember we're still talking about him, he frequently interrupts. What do you think this could mean? Well, some of the meanings that this could mean is that he has a hearing loss, but is unaware or in denial. He could have an acute health issue related to his ears. He could have cognitive decline or involvement, or it could just be that he's anxious and that's how he deals with it. We're going to look at the external ear when we do the physical exam. We're looking for symmetry. We're also looking for any deformities. We're looking at the external auditory canal and tympanum, and that's done with an otoscope. So when we look into the ear, this is what it should look like. And the tympanic membrane should be nice and clear. And we should tip the patient's head towards the opposite shoulder. We should grasp the top of the auricle and gently pull up and backwards to straighten the canal. The otoscope is held in the examiner's hand and stabilized on the patient's cheek by fingers. and it's inserted slowly. A tight seal is essential during this step, and the canal is observed for size and shape as well as color, amount, and type of cerumen, so the wax in their ears. The tympanic membrane should be pearl gray, white, or pink. It should be shiny and translucent. We should be able to see the malleus through the tympanic membrane. It should be concave with crisp edges, and fuzziness may occur with a bulging or retracted tympanic membrane. Some of the tests that we use for acuity include audiometry, which is a very effective screening tool. It uses tones to establish hearing thresholds. It is reported in hertz. That measures the tone frequency, so the different, whether it's a high-pitched tone or a low-pitched tone. Decibel measure the intensity. Normal speech is about 40 to 65 decibels, and a soft whisper is 20 decibels. We consider somebody to have hearing loss if they have hearing loss above 20 decibels. A 40 to 45 decibel loss is considered a moderate hearing problem. So AO had some other studies, and they indicated that he would benefit from a hearing aid, but he refuses. His wife, however, is very interested in him getting a hearing aid. So what do you think you should do? Well, try to understand his reason for refusal. It could be that he's embarrassed with the idea of wearing a hearing aid, so his self-concept may be involved. He may have previous experience with people with hearing aids. He may have knowledge of available or lack of knowledge about the new technologies. He may think that he's got to have a big giant hearing aid on the back of his ear, and that's not the case anymore. He may be concerned about how expensive they are. A set of hearing aids runs about, I'm trying to remember now. I want to say they're around $4,000 to $5,000 up. And insurance usually does not cover for hearing aids. And there may be some values or cultural preferences that have made him feel that this is just not an acceptable thing. So we may have to get support from the wife for him to start doing it. It could be as simple as, well, why don't you guys go home and think about it? And if the wife nags him enough, he may decide to come back and get his hearing aid. He would need to have a referral to a hearing aid specialist, and you would want to suggest a follow-up appointment so that they could think about the options. There are 3 questions here. If you look in the notes section, you will find the answers to each one of those questions, but just something for you guys to practice with as you're thinking about these 2 hearing and vision issues. And there will be a part 2, which will be longer. Sorry to say that, but it should be a little bit longer than this one. Talk to you guys soon. Good night.